Hello? Ooh.
Hey, everybody.
Ale?
Open my mic, please. Okay.
We can hear you.
Can you hear now?
At least I can hear you.
Okay. Martin?
I can hear you, both of you.
Okay, good. So, Martin, can we decide the order? So, Thomas,
sorry, guys, we are live now.
Okay. Thomas, you go first.
Okay. Hello and welcome. Can we be heard? Well, seems so. My name is Thomas Rösch, and on behalf of my friend and co-organizer Alessandro Repici, we are very happy to be here. You have seen our motto, anywhere, anytime, and this is more than true, because both Ale and myself are in Roma, in beautiful Roma, with Guido Costamagno's course, but we always carry endoscopy on air in our heart and our brain. So here we are to welcome you all to one of our most exciting satellite events of endoscopy on air, EOS guided biopsy you have seen, and I'm very happy to hand over to Alessandro for further introduction.
Thanks, Thomas. Also from myself, very warm welcome to another satellite with endoscopy on air. Very pleased to have Mediglobe as a sponsor. Mediglobe has very new solutions for US biopsy, and also I'm very grateful to Mediglobe to have supported from the beginning endoscopy on air also in the space of pulmonology, where Mediglobe has a lot of innovative devices. So it's a sort of very strong partnership. We both very grateful, and I must say we work very nicely with the Mediglobe team. So thanks for being so supportive of endoscopy on air. This is Tissue is the Issue. It's a fantastic satellite. There will be some of the superstars of US. I'm not an US expert, but I want to remind to the young generation that Peter Willman was basically one of the father of US and US FNA and biopsy. And also we have other superstars from different countries, including Professor Ito from Japan. So I will be following the entire satellite. I will learn a lot, and I hope everybody will be super happy at the end of the meeting. And now I hand over to you guys.
Yeah, thank you. And also a warm welcome from my side. Welcome to the audience and the speakers. Alessandro, you already mentioned two of them. It's a pleasure. It becomes slowly routine, but I'm still quite nervous. We're having a big audience, but it's a huge pleasure to be here and organizing that. And I'm excited to listen the next couple hours to see what we are showing, what our doctors are here showing. Yeah, we started last year the masterclass, as you said, Alessandro, with pulmonology on air. Yeah, now the next step is going into US, and there's definitely more to come. Just to have a quick overview about the Mediglobe Group, yeah, we are manufacturing and distributing worldwide in more than 120 countries our products. There's a huge distribution platform we have, and also our own subsidiaries covering mainly Europe, but also in Brazil and going further to APEC. Yeah, again, it's a pleasure to be here to support endoscopy on air, which I think it's a huge platform and an opportunity to get connected with people. Specific in the last 2 years, it was very difficult for all of us, and I really appreciate that. So I don't want to talk too much about the Mediglobe itself. I think the exciting topic will come with live cases and lectures. And before I hand over, I just like to remind here, our journey in ultrasound started already in the 90s. And one of the profs we have today here, and I'm very proud, and I know him since a while, is Professor Willman. And over the years, he supported a lot, and myself was a lot on the road with him to see clinics, to do trainings. Yeah, and lately in 2021, we launched our new FNB needles. And I think enough from my side, but Prof. Willman, it's a real pleasure to have you in this event, and you know us and the products very well. So I'm excited to listen and watch to you, and I'm sure you will tell us later about the other speakers here. So thank you very much and enjoy the event. Peter, I think you need to unmute.
Yes, I already unmuted. Thanks a lot, Martin, and yeah, just to give a short introduction to this wonderful event. I must say it's really a pleasure for me to be part of this together with my the other speakers. My name, as you know, is Peter Willman. I'm professor at Herlev Hospital, which is a university-based hospital in Copenhagen. And as Martin said, I'm also actually the father of this method, including the first to also be part of the development that was created in the early 90s together with Mediglobe. Many years actually, before other companies realized the relevance of this method. So it's a great pleasure to be sharing this together with Professor Julio Iglesias Garcia. Julio is an associate professor of medicine at University of Santiago de Compostela, and he's also head of the endoscopic unit at the Department of Gastroenterology in Santiago de Compostela. It's also a great pleasure for me to be sharing this with Professor Takao Itoi, who is professor and chair of the Department of Gastroenterology and Hepatology at Tokyo Medical University in Japan. And not least also two excellent pathologists. And this is going to be a really interesting discussion seen from pathologist's view. Dr. Hector Lazar Iglesias, he's a pathologist at the same hospital in Santiago de Compostela. And Dr. Ihab Abdulkader Nalib, he's also a senior pathologist at the same institute. But enough for introduction. Let me share my screen with you and start my presentation. So, US guided biopsy, the evolution from A to B. What I meant was from aspiration to biopsy. Before I will drop into what I want to discuss with you, I would like to ask you to answer these questions. Those of you who are doing US
Mr.
guided,
Chairman, please go into presentation mode, please.
Yes, I will do that. So, to those of you who are doing US guided biopsy, please vote. How often do you use fine needle aspiration? How often are you using fine needle biopsy? Is it never fine needle aspiration, always fine needle biopsy? Is it 25%, 75%, 50-50, 75-25, or are you only using FNA? 100% and 0. Please vote. So this is really going to be interesting to see, because it may be, I think, and I hope that we may be able to change your mind regarding the number of cases where you use FNB versus FNA. So right now, many are actually using FNB. It seems 75%, that is the lead, 75% versus 25%. So it seems today that actually our listeners seems to be more in favor of FNB than FNA. And I think that's I will try to close this one. So is the voting over?
Yes.
And I should share the results?
No, just closed pop up.
Yes, that was it. Okay, so yeah, this was an interesting. More are using FNB than FNA today. So the aim of my talk is to stimulate the discussion on when, how, and why US FNB is preferable over US FNA. I would like to give you a short history of US guided FNA, and then very short established indications and results of US FNA, and then what we are actually going into, why US FNB And what is different from FNA? Then the results comparing FNB, FNA, and also a little about the technical difference between these two procedures. And very important discussion, specimen preparation, and finally a look into the future. So Martin already mentioned it. I don't want to touch more upon that, but actually my history started in 1988 when I got a prototype without a biopsy channel in my hands. And from 1991, we got the first instrument made by Pentax with a biopsy channel. And from that start on, we started on developing prototypes together with Mediglobe. As you can see, this is the first prototype that was being used by my group. And now you see all needles today are basically constructed on the same frame as the one we started. But in the beginning, we didn't know what were the indications. And actually, if you look at the authors of this was a publication that was shared. It was the preliminary results from Moritz Wiertzema, me, Mark Giovannini, and Kenny Chang. And for years, this gave us actually a very good insight in where were the indications. And we know also that the complications are very, very few, sorry. But before I'm coming to that slide, you know, staging of upper GI cancer, staging of lung cancer are major indications. Primary diagnosis of mediastinal lesions, lymph nodes, submucosal tumors, pancreas, biliary tract, and adrenals. And we know for solid regions, the sensitivity lies in the range between 60% and 95%, depending on lesions. Less in submucosal tumors than in, for instance, pancreatic cancer or lymph nodes. For cystic lesions, it's disappointing lower. But these are complications, and they are few. The specific morbidity in many, many patients seems to be around 1%, but many of these are post-procedure pain, so mild complications. Pancreatitis of pancreatic biopsies, of course, is also seen. But rare and relatively low complications. Today, the standard needles they're out there. There are probably also other companies making these needles. Basically, they work based on the same principle as our original needle. We have done a lot of publications to improve technicalities of the procedure in order to improve the accuracy, with or without stylet, with or without suction, so on and so on. I will not go further into this, but I would like you to focus on the following statement. Similar sensitivity regardless of needle size, but bigger needle takes bigger bites. And also you should be aware that microcores are seen in standard FNA needles between 40 to 80% of the cases. But bigger needles, the bigger the needle, the more histology you get. So there are needles on the market, and there are, first I would point on this ProCore, which is a reverse bevel. This was the first so-called FNB needle, and then the second was the ProCore reverse bevel, and what I consider the third generation is the crown cut needle types like the Shark Core, the Acquire, the Top Gain, but I will not consider the ProCore forward bevel as part of the third generation. I will tell you a little bit more about that and why. So these are what I call second generation F&B needles, both the reverse bevel and the 20 gauge forward bevel needle. We know from meta-analysis that core and standard needles, FNA needles, were comparable in terms of diagnostic accuracy. These were the first generation, second generation pro-core needles. The number of needle passes for diagnosis was significantly lower with the core needle. So this is what you gain. If you use this kind of needle, you can do 2 passes instead of 3 passes with an FNA needle. There was no significant difference in the procurement of optimal histological cores between core and standard needles if you use the same needle size. So therefore, this publication, which was the 25 gauge FNA needle versus a very big FNB needle, the reverse bevel needle, not surprisingly concluding that the 20 gauge FNB needle outperformed the 20 gauge FNA needle in terms of histological yield, but the sensitivity was the same. This is what I call third generation crown cut needles, top gain, shark core, acquire. What actually this publication is going to tell you is that this was the first publication who actually were the authors. This was from the group of Shyam Baradiulu, and they were the first to actually measure the size of the cores. Median tissue area was 2.9, and we also realized that compared to Rose, this needle also were in the same had the same sensitivity as Rose, but this is a randomized studies in 50 patients with pancreatic lesions. And it showed that there was no difference between a crown cut needle and a fork tip needle. So I consider the crown cut needles similar. Another publication which tells me a lot, and this is why I wanted you to take notice of the this bigger the needle, the bigger. But that doesn't hold true when you are talking about F&B needles, because this is the 20 gauge pro core needle, which is a big needle, compared to a 22 gauge acquire needle, which is the crown cut type of needle. And look at this. The size of the biopsies were double the size as the bigger needle, 20 gauge pro core needle. So significant higher mean cumulative lengths of tissue core biopsies per needle pass with the 22 gauge acquire needle compared to the 20 gauge pro core needle. This is important knowledge. And also this is a crown cut needle, also clearly demonstrating that for submucosal tumor, what you need to use is a crown cut needle and not an FNA needle, because you see the diagnostic yield between a crown cut was 92 versus 46%. So there's no doubt in my mind. This has also been shown when we are talking about diagnosis of autoimmune pancreatitis, showing that a crown cut needle actually diagnosed type 1 autoimmune pancreatitis in 78%, while the front cutting needle, side cutting needle only in 45%. So again, the conclusion, this is the field for FNB. There are significantly differences between the needles, both in how to perform the biopsy, but also in how to prepare the specimen. This is what I call actually the stepping method, because a crown cut needle is not as sharp as an FNA needle. And you really have to stab your way into the tumor. And also when you're in, you have to stab by forceful, sudden forward movements in order to make the needle tip move inside the lesion. Look at this video where you can get the feeling that I really had to stab my way in order for the needle tip to move and collect tissue inside the needle tip. So, specimen preparation. Again, you should be aware of the difference between cytology and histology. At cytology, we are looking at single cells or clusters of cells that is smeared onto a glass slide. By histology, we are looking at a preserved histology. Tissue architecture is preserved. So the preparation in your room is different. For the cytology, you have to smear, as you see on the slides, and color it also either in the lab or in the procedure room. But for FNB, you actually have to place it, as you do with histology, in formalin. You can do also make an imprint of your histology, but after the imprint, you have to put it in formalin. And prepare this as every other histological sample in formalin and cut it and finally do your immunostaining and all what is needed to be done. So I would suggest the following. The indications for EUS FNB is whenever you want to differentiate between tumors. This might be, let's say, is this a metastasis from a renal cancer or a primary pancreatic cancer, but also submucosal tumors, no doubt. Lymphomas, we need more tissue for these. Neuroendocrine tumors, we need more tissue. Autoimmune pancreatitis, for sure. Sarcoidosis, sarcomas, and then where more cellular material is needed for molecular analysis, that can be in pancreatic cancer, and this is a growing wish, and lung cancer. So we are walking into personalized medicine. And whenever you really want good material for immunohistochemical analysis, then this is also the method. But as I said, we are walking into also molecular analysis, into genomics, transcriptomics, and proteomics. This is just one publication demonstrating that there is a potential here. This is, the authors looked at insufficient, inconclusive biopsies and demonstrating that KRAS mutation analysis actually were able to show oncogenic mutations in half of the inconclusive biopsies. This is also a clear demonstrating, this is a randomized study between a 22-gauge FNB needle and a 22-gauge FNA needle, clearly demonstrating that the FNB needle provides more histological core tissue and adequate nucleic acid yield compared to FNA. So whenever we need molecular analysis. This is for FNB. We are presently also growing, and I know others are also heading in this direction, but we are growing organoids in order to chemotype these organoids to be prepared to better treat these poor pancreatic cancer patients. We have to do something about that. So coming to my conclusions, US-guided fine needle aspiration has undergone more than 30 years of evaluation. A wide range of established indications of US FNA exist, including staging as well as primary diagnosis of a variety of lesions. Bigger sized needles give more material for cytology or histology, but diagnostic yield is similar between different size of needles, at least when it comes to FNA. Standard US FNA needles are not inferior to reverse bevel needles when it comes to sensitivity and harvesting of core tissue for histology. New crown-cut core needles significantly improve histological tissue harvesting from solid lesions. Preparation of the US FNB specimen differs from FNA and should not only be prepared for cytology. US-guided FNB may, in the future, become an important method in tailored oncological therapy. So, thank you for your attention. And I think we will now move on. And I will give the word to my friend and an excellent physician who have been doing a lot for US and US-guided biopsy, Professor Takao Itoi. Takao, please take over.
Thank you very much, and a very nice presentation. Congratulations on the Peter, my friends. Hello, everyone. I'm Takao Itoi in Tokyo Medical University, and today I'd like to show some cases diagnosed by US FNB in the pancreatic region. So, share my slide. So before showing my case, I'd like to talk on the US FNB shortly. So as you know, US-guided fine needle aspiration biopsy in the pancreatic region was reported by Professor Peter Biermann in 1992. Notably, he described not aspiration cytology, but aspiration biopsy here. So although the figure was cytology at that time. Since I belonged to Department of Pathology 30 years back, around 1993, after completing the initial residency of medical residency, I believe that histology has several advantages to cytology. Already Peter mentioned, for example, a lot of information, including structure atypia, immunostaining, and translational research. So since 2002, when I've studied US FNA, our FNA meant current FNB, apart from type of needle, in which sample was placed directly into the whole marine, and we satisfied our outcome of FNA. In particular, we have taken care of whitish part of the sample like this using a pincet, and so eliminate the core tissue into the whole marine. So in particular, and fortunately, the Japanese endoscopist, one Japanese endoscopist, Dr. Uwashita, has scientifically proven its importance with Mohs method, as you can see. Also, we've reported the usefulness of immunostaining using FNA sample for a long time, like this. So nowadays, third generation FNB needle make it possible to obtain real core tissue sample or to expand the possibility. Actually, our recent study showed FNB needle with FNB with Francis needle could obtain large enough sufficient core tissue. So also latest multi-center RCT study between standard needle and the Francis needle from Japan revealed the Francis needle is superior to standard needle with respect to diagnostic accuracy purpose, particularly in patients who required immunostaining and the number of passes when using modes. Another multi-center RCT study also reveals FNB alone is non-inferior to EUS FNA plus loads, and it's associated with fewer needle passes, shorter procedure time, and excellent histological yield at the comparative cost. Next, I'd like to show some FNB cases. So let's talk with Peter. CAT scan showed atrophy of a pancreatic tear parenchymal. So how do you diagnose? By the CAT scan. So we did perform the US. So US shows slightly the lobulated and hyperechoic line and the tear of pancreas. So you can see a small mass. What do you diagnose this? Yeah. And using Peter.
Yeah, but for sure I would use an FNB needle for that.
Yeah.
Yes.
And so what's your diagnosis?
Yeah, to me it could be either a primary adenocarcinoma or a neuroendocrine tumor.
Thank you. So you can see very nicely core tissue. And so the final diagnosis of FNB pancreatic ductal cancer. So you can see a rejected specimen. So it showed invasive ductal cancer. So, but a very small lesion in the pancreas. So next case 2. Also the transabdominal ultrasound showed small region of the body of pancreas. So I also did US and the ESFNA. So how about this region, Peter?
Again, in my practice today, we would use FNB.
Yes, and what is the diagnosis? Pancreatic cancer?
Yeah, pancreatic cancer or a neuroendocrine tumor.
Mm-hmm.
And therefore, I would choose an FNB needle. Mm-hmm. I mean, if this was a patient with multiple metastases and you wanted to make sure that this is from a primary cancer, things like that, and it's only a matter of demonstrating that this is cancer or not, then you could use an FNA needle.
Yeah, I use a FNB needle.
Yeah.
And so you can see specimen showed a small round-shaped cell aggregation with hyperchromatin. So special immunostaining shows the chromogranin and the synaptophysin was positive with lower Ki67 index, positive index. That's why final diagnosis is net G1.
Yeah, I fully agree.
Agree? Oh, you were right. You're right. So next case, I'd like to show the case using the FNB needle top gain. Very nice needle, as already mentioned. So CAT scan, case 3. CAT scan shows a low density area, small area in the body of pancreas, and the diffusion weighted image showed the decrease of the signal at the same portion. and we did US and the USFNA. What, Peter? How about use FNB without question? Yes.
Without question, yes.
Yeah. And what the diagnosis?
It looks like a primary adenocarcinoma.
Primary adenocarcinoma. Yes. Irregular merging and hypoechoic region.
Yeah.
And so top gain obtained very nice core tissue, more than 5 millimeter in length. Very nice, you can see. And so you're right. So the final diagnosis.
We don't need needles. You and I only have to look at the US.
Yes, thank you. And so not only the epsilon, but also the interstitial area could be obtained like this. Very nice. So next case, patient had obstructive jaundice with CA99 elevation. So cholangiography showed the distal bile duct stricture here, and the CAT scan shows the mass in the head of pancreas here. So I performed USF FNB. So also you use FNB needle, right?
Yes. For sure.
What's your diagnosis?
I mean, this could be pancreatic cancer, but it can also be a cholangiocarcinoma. Yeah. But when I'm looking at your doing the biopsy, it looks as if it is an FNB needle.
Yes.
Because as you can see how much you moved the tumor in order to penetrate.
Okay, so sorry for small information. And finally, we can get enough tissue. So as you can see, the specimen showed the striform fibrosis and chronic inflammatory cell infiltration, like this. And the IgG4 immunostain was positive.
Yeah, of course. That could
furthermore, obliterative phlebitis by EVG staining was positive. So finally, autoimmune pancreatitis was diagnosed.
Yeah. I should have thought about that as well. And it's of course that is why biopsy is so important. And not only imaging.
Okay. So time is limited. I think last case, case 5, you can see CAT scan shows low density area around the body of pancreas here, and embedded or suspected embedded invasion and the celiac or splenic artery. So we perform we use FNB using at that time 25 gauge needle because we targeted hypoechoic mass along the celiac or splenic artery, sometimes are dangerous. In order to avoid the intervening blood vessel, we did it using Doppler mode. And here, surrounding area of the artery. Fortunately, it's very nicely imaging, longitudinal imaging was safe. So how about the Peter?
Yeah.
You use a 22 or even 19 gauge needle?
No, I will use a 22 gauge.
Oh, 2 to 22. Oh, you are brave. So I'm afraid of the unnecessary, unexpected adverse event, or like a bleeding, or because very close to the vessel. artery. That's why I hesitate 22 gauge needle. At that time, 25 gauge needle or FNAB needle. And finally, so we can get the tissue here. The specimen showed invasive adenocarcinoma in sparse in interstitial tissue. Maybe mainly the invasive area. Okay, final diagnosis: pancreatic duct carcinoma, mainly the growth type of main growth type out of pancreas type. Okay, so time is limited. One more? Yes,
I think it's. I think you have one more. Yes.
Okay, one more. The last case, case 6. CAT scan shows here. You can see a small low density area, hypovascular area in the head of pancreas. You can see here. Very good. The hypoechoic and the irregular margin. So what diagnose?
Again, primary adenocarcinoma, but it can also be a new endocrine tumor.
Yeah. I agree. Maybe I saw the pancreatic duct carcinoma and the 22 gauge FNAB needle, and so here you can see a specimen. The specimen shows a spindle or cells with moderate to severe pleomorphism and marked cellular atypia with high Ki67 positive cell.
That's interesting.
Yeah, final diagnosis, leiomyosarcoma.
Wow.
Unbelievable for me. So
that would probably be difficult with an FNA needle.
Exactly. So one information in this patient, we performed a complete pancreatic duodenectomy. However, the recurrence happened in a year and died. So very, very crazy tumor here.
Yeah.
Okay, my case finished.
Thanks a lot, Takao.
Thank you very much. Thank you for your kind attention.
Thanks a lot. Beautiful team you have. And this was awesome. I think we should move on and go into our panel discussion, when to use FNB and what is the advantage. But before we do so, Giulio, my friend, you will give us a short presentation on guidelines, what is out there. So, Giulio, please share your presentation with us.
Okay, well, first of all, I would like to thank Endoscopy On Air and Mediglove, and of course, Peter, Takao. Being here together with you is an amazing pleasure. And I think it's becoming a very nice session, because this is still a very important topic. And this is day-to-day routing. I mean, we talk about very different kinds of therapeutic AUS, but what we usually do every single day is sample, sample, and sample. So I think it's very nice to have a good overview on what has been the development and where are we going with AUS-guided tissue acquisition, and mostly these days with a biopsy. So let's go to see what the guidelines are telling us about this very nice topic. So when we talk about guidelines, this is just a brief summary on all of the different guidelines that are available today, focusing on AUS-guided sampling. So it is not only the ESG guidelines from 2017, there is a very recently guideline on tissue sampling on 2021, but it's not only ESG, we have NCCN guidelines from Korean papers and Korean groups, from Japanese groups, American groups. So believe me that it's been a lot of difficulties trying to focus on what are the guidelines telling about AUS-guided sampling. So I will just try to focus in the European ones, in the ESG guidelines on this topic, and let's see, and let's try to discuss, all the three of us, on what are our impression on what the guidelines told us. But even before beginning, we need to be aware of what are the real indications, and this is probably the first stop to do, because this is what has been commented in the EFSUM European guidelines on ultrasound. So here you can see the frequent established indications, the less frequent, and contraindications that I think are becoming lower and is the standard contraindication for any kind of endoscopic procedure. And what ESG told us about indications in 2017. So the accepted ones is for sampling solid pancreatic tumors, cholangiocarcinoma and ampuloma, cystic pancreatic lesions, although this is not really biopsy. Well, I will just give a word to Peter because I think we're moving to the biopsy of cystic pancreatic lesions, but also subepithelial lesions, the enlargement of tumors, of luminal tumors, gut wall tumors, mediastinal diseases, lymph nodes, focal liver lesion, and also diffuse liver disease, because now we've reached the potential indication of AUS-guided liver biopsy. And in the miscellanea, we can include left adrenal gland. I think with all sample kidney lesions. So this is just, I will just deserve a comment from Peter and Takao about what do you think about what the guidelines are telling us about just diffuse talk about indications.
Yeah, I mean, something are clear indications and other things are, let's say, moving in that direction. I fully agree with the indications that is written here. I'm not sure still with focal liver lesions and diffuse liver disease that the discussion has been 100% settled between transcutaneous and EUS guided. But otherwise, I mean, with EUS, we are so close to regions that is actually only reached if you open the patients. So there are, of course, clear indications and well-founded indications for EUS-guided biopsy.
So for me, the clinical guideline of USFNB as well as the USFNA is very important. And I think expanding indication is very welcome for using this procedure. However, a lot of guideline sometimes confusing from the beginner to senior and echoendoscopist. So we should make a good guideline for the in particular beginner.
Yeah, if I can just shortly comment on another topic, I think is important, because guidelines that is made yesterday may already be too old. And the guidelines in 2017, I think, is probably already getting too old.
Yeah.
And that we also should think of, because we get more and more evidence that drives also guidelines in another direction.
I think I fully agree with both of you. I mean, we just reached very important ideas. One is that the guidelines are not the holy grail to follow. I think there is expanding indications. And of course, there's another very important topic addressed by Professor Itoy. It is not the same an expert AUS endosonographer than a beginner. So probably if you have expertise, you can reach further stations, further lesions that probably is not the best for the beginners. And at the end, guidelines is just opening the door for what is very well established. And Peter is very correct. Well, this is 2017. This is 5 years ago. 5 years ago is like in another area. So let me try to go ahead to keep the discussion, but I think it started very interestingly. So next thing is about what the accuracy we need to expect. And I know that Takao and I know that Peter have reached this concept, but believe me that what the data today in 2022, I think we should move in a sensitivity more close to 90% than 70%, although guidelines initially comment that a 70% could be acceptable. Honestly, I think we need to move to 90%, and going below those levels, we need to look what we are doing because we need to improve. And in terms of specificity, I think we all agree this should be around 90 to 95%. So this is what the guidelines told us about what are the expected accuracy when you start to, and this is one of the topics that you need to look when you try to analyze if you're doing a good job in your unit or not. So this is just a brief summary on accuracy, but there is something very important at this slide that I took from your presentation, Peter. Sorry for it, but this is crucial because it is one of the big changes guiding and drafting the guidelines is that we move from FNA to FNB. And of course, it's completely different indications when you have an FNA needle than when you have an FNB needle, because it is completely different information when you move to cytology, when you move to real histology. So this is, again, very important. And the guidelines in 2017 from the ESGE were mostly focused on FNA needles, and just include a brief comment on Procore and even shorter comment on the new Francine type needles like the Top Gain, like the Charcot or the Acquire. So this is also for me another very important point. But now, with this background, what do we know from the guidelines? So this is what was commented by the guideline in 2017, when to use FNB and what is the advantage. From the technical point of view, the guidelines state that for routine AUS-guided sampling of solid masses and lymph nodes, what is recommended is to use 25 or 22 FNA or FNB, equally recommended. So please, Peter, I need a comment from you on these 2017 guidelines, please, because I think we need to switch this guideline, in my belief.
Yes, I fully agree. We need to, work on new guidelines that is more up to date. Because, of course, an FNB needle is preferred over an FNA needle.
In fact, if we look at this another statement, they just recommend FNB 2017 when on-site cytological evaluation is non-available. And we know, I think with the expertise after these 5 years, that FNB is as accurate as ROSE.
Yes.
So we will discuss this on a live case and from the view from the pathologist, but this is one of the statements. So although this is what is placed in the guidelines, it is not real what we are trending to do now. So let's move on.
Actually, that just a short comment, because there was in endoscopy January issue a very good publication from a Canadian group showing this, what you were saying, that ROSE is not superior to FNB. So you can spare costs, you can spare time, so there are many advantages.
In fact, I just brought these guidelines from the Korean Society of GI, published in Clinical Endoscopy 2021, which is more recent. And they still, if you just take a look and shoot biopsy needles rather than standard needles we use, they still 2021, because the studies are focused until 2020, they still put in the same level, almost in the same level, FNA and FNB needles, and they've just recommend FNB when there is the need for an histological core tissue specimen, talking about focal autoimmune pancreatitis, neuroendocrine tumors. So that's the only indications in which they recommend FNB needle. But again, I think, and Takao showed us very nice cases that I think FNB, even for pancreatic cancer, with all of the new ideas on guided therapy, I think we need to move to obtain a better sample. So I think just to say cancer, yes, no, probably an FNA needle, it is okay. But I think, honestly, in my opinion, and I just want to have a word from Peter and from Takao, I think today it is not only cancer, yes, no, we need to have more information when we sample any kind of lesion accessible for AUS-guided sampling.
Yeah, I think that's where we are heading towards. I think the more we are spreading this, let's say, more or less at least evidence-based knowledge, I think more and more people will start doing FNB instead of FNA.
I also totally agree with Peter and Furio.
Okay, so let's just go for the indications and what is the guidelines telling us about indications. And of course, AUS-guided FNB is the standard of care when we face a solid pancreatic lesion. So whenever we see these lesions, AUS-guided sampling is the way to go. And in the latest indications, they state that this is the first line procedure when a pathological diagnosis is required. I think there is no we all agree that for solid pancreatic lesions, AUS-guided sampling, and I think better with FMB needles, is the first line approach in this indication.
Yeah.
So let's move for the accepted indications in the guidelines. So next is, I call it lesions from the gut, but it's probably luminal lesions, which is more appropriate, but probably for a better understanding is, I think for subepithelial lesions, recent guidelines 2021 suggest that although on-bite biopsy, it can be initially thought as a very good indications, they state that if it's really an indication to sample a subepithelial lesion over 2 centimeters that we expect to have a potential chemotherapy or even before surgery, to be sure that we are dealing with a real GIST malignant tumor, AUS-guided FMB needle is the first line approach. And the other good indication is when you have a diffuse thickening of the wall, like in a gastric linitis. Today, the first approach, better than go to bite or a macro resection with a snare, probably the best approach is to go for an AUS-guided sampling with an FMB needle, because we can do a lot of different techniques with this sampling. So I do not know if you agree, both Takao and Peter, with these indications in luminal lesions.
I fully agree.
I also agree.
Okay, so let's go moving. And I don't know if I have the right to talk about mediastinum and lymph nodes with Peter on board, but for mediastinal, lymph nodes, unknown on origin, ESG recommends performing AUS-guided or EBUS-guided sampling whenever the pathological result is going to affect the patient management. And of course, I think this is an amazing and great indication, and I think in all centers we are trying to do more and more. And I just make a brief comment in Santiago. We have a straight relationship with our pulmonologist, with our hematologist, and with the people from the lab, because I think this is a very simple ambulatory process that you can really diagnose without going to surgical approaches in mediastinum and lymph node approach. So I don't know what's your opinion of both Takao and Peter on this indication.
Oh, indication, yeah, please, Peter.
No, you do.
Okay, so indication is acceptable, but in terms of the needle selection, 19 gauge FNA or FNAB needle. In case FNA, 19 gauge large caliper is acceptable, but in terms of FNAB, 22 gauge needle is enough, I think. Thank you.
If I should comment something, you know, the pulmonologists also do both via the esophagus, or at least many of them do, but also via the trachea, of course, to sample lymph nodes. But for the trachea, there are other, let's say, physical properties that could be a challenge. And very often you have to penetrate a cartilage ring in order to get outside the trachea. And this is, of course, problematic when you have crown cut needle types. But I think there are ongoing studies in pulmonology, and we have to look at the results from these studies.
Okay, I agree. We do it routinely, and it's true that whenever we suspect lymphoproliferative disease, we usually tend to use a 19 core needle because we want to obtain the biggest sample for the pathologist and also for flow cytometry.
Yeah.
Just coming for and this is the guidelines, ESG 2021 liver indications. So look, ESG suggests today, when AUS-guided sampling is indicated, to use large caliber needles, 19 gauge or FMB needles for suspected parenchymal disease. And I know there is a lot of ongoing trials to try to see if AUS-guided were able to obtain a good core to make the analysis, but we have data that are promising, but we need to stay this for the future. And look, for solid pancreatic lesions, and this is what ESG says, performing AUS-guided sampling for suspicion of malignancy if the pathological result will affect the patient management and the lesion is poorly accessible or not detected at percutaneous imaging, or the sample obtained by percutaneous route has repeatedly yielded an inconclusive result. So I think this is open the field of a new potential indication of AUS-guided sampling when we For instance, I just give you an example. When we're staging a lung cancer, we see a small lesion in the liver. I think we routinely use the AES-guided sampling. We don't stop and go for percutaneously. We do it in ambulatory environment. We just go ahead and do the biopsy from the solid liver lesion. And we also usually do it when we are doing a pancreatic mass with liver mets. So I think this is the recommendations, and it is an easy and very accurate approach to reach solid liver lesions AUS-guided.
Just a short comment on the ESGE recommendation that 19 gauge FNA or FNB needles should be used for so and so. I think for the new guidelines to be written, this should be stated as crown cut needles and not in general FNB needles.
Yeah, I agree with you, Peter, 100%. I think the good sample is, I mean, we are doing it. We are conducting a trial comparing percutaneous with FNB, and we're using the crown needles, the 19 crown needles. And I think, honestly, there is not really the field for a 19, even 19 cytological needle if we have available the crown needles.
Mm-hmm.
Okay, so just to keep going, because so at the end, this is the summary of the guidelines that I took it from you, Peters, just to be focused that we are aligned with the same ideas. So I'm not going to take time, because at the end, this is what you have already commented in your presentation, just to tell that I fully agree with your approach, absolutely. And so the main advantages from the technique, just coming to the very much end, obtaining better quality samples with a smaller number of passes is one of the advantages of FNB needles. Accuracy similar to FNA plus ROSE, but for time and money, it's better to use the FNB needle, that you have the pathologist in the room for time, cost of the pathologist, time of the procedure. So probably this is also need to take into account. And according to indications, of course, core samples will allow better evaluation. You comment on this, both of you, immunostaining, molecular profiling, and it is not cancer, yes, no. We need more and more information because we are moving to personalized medicine. And this is absolutely key in 2022, and it's going to be even more important in 2023, 2024, and for the future. So just want to say thank you. You know that I am transmitting from the room, so I need to switch and go. So yes. Peter, I give you the word for the end while I move fast to the room, because Enrique is there, so I will let you introduce the live from Santiago.
Thanks a lot, Julio. You run to your room, and thank you for sharing these slides with us and stimulate the discussion. Now we are looking forward to see what Julio and his team have prepared for us. I know it's going to be really an interesting case, highlighting, let's say, the room for FNB versus FNA and how to prepare these specimens. So less on maybe how to perform the procedure, but a discussion on FNB versus FNA. So, Takao, how is it in your unit?
Yeah, in my unit, so we frequently use FNB.
Yeah.
So recently, both crown cap and others 50-50. Not always a crown cap.
In my unit, more and more, or less and less, more and more crown cut. It's actually getting more and more rare that we're using an FNA needle. When we are using FNA needles, this is often for therapeutic use. With guide wires, 19 gauge FNA needles, so on and so on. But for diagnostics, only in cases where it's only a matter of diagnosing cancer.
Yeah, exactly. Therapeutic. In the near future, the therapeutic only, if any needle, right?
Yeah. We are heading in that direction, no doubt. So, are you ready in the?
Yes, we are. Can you hear us?
Yes, we can.
Yes.
Hello, good to see you.
Hello, Peter. Very nice to see you again. And hello from the endoscopy unit of the University Hospital in Santiago de Compostela in Spain. It's our pleasure to be part of the Endoscopy on Air. And in this occasion, I would like to thank Mediglobe for their support for the meeting today. And my name is Enrique Dominguez Munoz. I'm the head of the Department of Gastroenterology. I'm here surrounded by all my team. And before following, I would like to give the floor to Julio to present the case.
Okay, so just I switch from one room to the other. So, well, again, thank you everyone for allowing us to be here in the unit. So we are going to present initially the team, so we can have the big screen. Okay, so we will go for the case. So this is the live case that we are going to perform today. So this is a 62-year-old male, smoker of 1 package per day, mild drinker with no family history of cancer, and never been to the hospital before March 2023. He was admitted to the cardiology department because a cardiac insufficiency as a debut, first time ever to be in the hospital. He was diagnosed of an atrial fibrillation with a Chat VASc of 2. A cardiopathy with a decreased function of the left ventricle was detected, although it was an improvement while the stage in the cardiology department. It was also a severe mitral insufficiency detected with a dilation of the right ventricle. He also has an acute prostatitis, and a very important information, he was diagnosed of a recent onset diabetes. So in the diagnostic evaluation, apart from the echocardiography from the heart, a lab test was performed with a normal hemogram, a slight elevation of gamma GT and phosphatase alkaline with a levels of glycosylate hemoglobin of 11.7, and cardiologists request a transabdominal ultrasound, and I want to show you the images because a pancreatic head mass was detected, 4 centimeters, but also with some small lesions in the liver. So the diagnosis from the radiologist was a pancreatic mass, suspected cancer with liver metastasis. So the goal of today with the team is to go for an AUS-guided sampling. Jose will tell us what he is going to sample. And the idea is to show how we are going to do rows with the pathologists, because we have here our pathologist team. They will be presented by Jose before. And also we will perform a second shot because we want to have the rows, but also we want to have a biopsy as we routinely do in the unit. So I just give the word to Jose that he was going to perform the case, and he will present the rest of the team.
Okay, hello. Good afternoon. I would like first of all to say hello all the people who are attending this live demonstration of Mediglobe, and of course to introduce the people who are working with us in the room, all the people. We have the nurses, Sandra and Alba. Of course, we have the anesthesiologists, Alejandra, our team of pathologists that are the best of the world. We have an Hector, of course, my colleague Daniel, my chief, Enrique and Julio, my chiefs, and also some trainees that we have from different parts of the world, from Madrid and from Verona, from Italy, Valentina and Guillermo. Okay, so now just going to the point, as Julio told us, we are dealing with a suspicion of a pancreatic cancer, and not unresectable pancreatic cancer, because we know that this patient have, according to the abdominal percutaneous ultrasound, some kind of liver metastasis, or it seems that we are dealing with liver metastasis. So the idea of this procedure is doing an FNA or an FNB to confirm that we are dealing with a pancreatic adenocarcinoma. The idea of this is to try to get material, enough material, in order to provide the patient with the possibility or the opportunity to receive some kind of chemotherapeutic treatment. In this case, as you are going to see now, with ascites, with liver mets, and with a huge mass in the head of the pancreas of 4 centimeters, it seems that the chemotherapy is going to be as a palliative treatment, not as an adjuvant treatment. So we don't have a lot of time, so we are going to the point. We are going to see the screen to see the pancreatic cancer that we have here. You can see the screen, a huge mass of more than 4 centimeters with a lymph node that is beside this huge mass. So it seems very easy to do, in this case, an FNA or an FNB. And the idea, when we are doing a US-guided puncture, is the material that we are going to obtain, what we do really want to obtain. So first of all, we want to confirm the diagnosis. To confirm the diagnosis of a pancreatic adenocarcinoma is not very difficult. So with a single cytological evaluation, it's possible to confirm the diagnosis. In those cases, we are very sure that we are dealing with a pancreatic adenocarcinoma. So that's the first point. We are going to confirm the diagnosis of a pancreatic cancer by using a cytological, normal, standard, traditional needle that we used in the past. And we are going to use, in this case, a Sonotip Pro Control needle. And then, if we need more material, we were going to use another types of needle, our histological needle. As we have the presence of an on-site pathologist, perhaps to use a cytological standard needle is my first recommendation in this case. Julio, want to say something?
Yes, we're going to use, as Jose commented, the 25. So it's a big advantage to have here Ihab and Hector. I would like them to be here with me. So this is the pathology team. They are the most important guys of AUS-guided sampling because everything depends on them. We just try to give them whatever we can, and with very scant samples, sometimes we ask for a lot of information. So I'm going to, Danny, who's with me, is going to give Jose the 25 gauge. So the idea today is to show how we manage with the pathologists in the day routine, how we manage the sample for smearing for an on-site. And the next is because we want to obtain a bigger sample for optimizing diagnosis, for immunostaining, and for potential molecular analysis. So Jose will start doing a 25 gauge for on-site because we use, as a recommendation from the pathologist, for on-site, we prefer the smallest needle to know if the patient has a tumor, yes, no. And then in a second pass, we will try to obtain a higher quality sample. And for that reason, we are going to do a pass with an FMB. In this case, we will use the Top Gain 22 gauge needle, which is the standard that we use for FMB. So, Jose, go ahead with the explanation of the.
Okay, first of all, I would like to remind that the 25 gauge needle is the thinnest one. So we have a thick needle that is the 19 gauge, and we have a thin needle that is the 25. So with the 25, when we are in a very angulated position, it's a very good needle because we can do it easier than by using a 19 or a 22. So now we are going for obtaining the sample, we are going to use a complete suction. We use normal suction with a syringe in order to take the material. And just in the case that we obtain a bloody material, then we avoid the suction. Now I would like you to see in the screen how we can detect, you can see here, the tip of the needle. Okay, this is the tip of the needle. So we are now going to do a quick shot in order to go inside the lesion. So we have here, you can see how the tip of the needle is. Okay, and now inside the lesion, this is very easy because this is a huge mass, so we have no any kind of complication for doing this. And now we're going to remove the stylet that is inside the working channel of the needle in order to do the suction. So
Jose, just a comment on the technique. Go ahead. Okay. What do you think about a slow pull, suction, no suction? Just to have a comment, not only for the pathologist, do you think there is a change on the quality of the sample based on if we use suction, no suction, slow pull?
I don't really know, and I don't really trust in all these techniques if there are some difference about them. I believe that the first option is to do suction and then to change. Perhaps the slow pull technique is very used by other groups, but I trust more in doing suction at the first pass. Okay, so now you can see the tip of the needle, and now with the suction we are going to do some movements inside the lesion. Another possibility now is doing the fanning technique. Okay, the fanning technique is just by moving the big wheel of the condoscope. You can see how we are moving the big wheel, and we are trying to target different sides of the lesion inside the lesion in order to provide a different distribution of the cells that we are obtaining from here. Okay, so now we can do many movements by moving the big wheel, and it's a very well seen the tip of the needle. It's very easy in this case because it's a very thin needle, 25 gauge needle, so with a 19 or a 22 is more difficult. And I believe that perhaps with this is enough in order to try to provide the pathologists with material for doing a cytological evaluation, okay? So after doing this, we are going to close the suction here, and now we're going to remove the needle, okay? So we remove the needle, and now we are going to...
Danny's key job is going to be now, because now it starts the most tricky part. Sometimes we don't realize how important it is to have a good management of the sample, and we try to go fast because we're always in a hurry. But this moment is crucial, absolutely crucial. So Danny is going to be helping Jose. Danny, what do you prefer? To use the stylet, to use air, to use water?
We usually prefer to use the stylet. I think that we can move or remove better the sample inside the needle.
So now we are pouring the material, any material until now, but we are going to pour the material into some glass slides in order to see by our fantastic pathologists.
Yes, and
we trust a lot of them.
What is also extremely important is how you do the smearing, because Hector and I have tried to show me and teach me how to do it, and after 20 years I cannot still do it as good as they do it. So it's very important now to see if we can focus on Ihab's hands, because it's very important to know how Ihab is doing very smoothly, how he is spreading and he is doing the smearing. This is absolutely key, because if you do it too strong, you can destroy the cells and you can make a lot of artifacts in the sample. So now that we have obtained a lot of material for smearing, remember this is a 25 gauge needle, so we've used it for smearing. You can see how they're doing the on-site management using different types of liquids to try to make the best fixation. But this is just to do a cytological standard evaluation. I can show you with for a moment that we have the micro here also in the room. So that's Hector's hands. So this is the micro that we also have in the room. Stable, he's always with us. Because then there is a matter of discussion when we use rows. So while they're doing all of these things, I can tell you that we usually use rows when we have not confident and we do not trust on the first result of the FMB that we have already performed. So if we never need to come back again to do another sampling, for the second shot, we always prefer to have the pathologist in the room. So now I think we are going to move back to Jose, because once we have the sample and while they are preparing to do the rows, we are going to do an FMB sampling. So you can see the difference with the FMB as compared to the FNA. So Jose, and please comment if you make any change in the technique when we use an FMB needle.
Yes, we are doing the FMB by using a core needle or a histological needle is exactly the same that by using an cytological standard needle. The technique is exactly the same. In this case, I recommend or I prefer to use this kind of core needles in those cases when we lack on-site cytopathology. So if we cannot do a rows evaluation, perhaps it's better to use a core or histological needle than a cytological standard needle. And another indication is that when we want to obtain a more adequate material or a better material, and for this, for example, not for the pancreatic adenocarcinoma, but perhaps for another kind of tumors that we have in the pancreas, that are the lymphoma, for example, is mandatory to use a core needle, or some other different types of diseases as autoimmune disease, for example. In those cases, we prefer to use a histological standard needle. Well, I don't know if you want to say something about the sample that we have obtained.
Well, it's a very high quality sample, but I will tell you the result after you finish the FMB needle.
Okay, so now we're going to use the 22 gauge needle from Mediglow, that is the top gain needle. And as I told you before, we are mainly using the core needles, the histological needles, when we lack of an on-site cytopathologist. Because with this, it's possible, perhaps, according to some studies, to reduce the number of passes that we are doing in pancreatic masses and in another types of lesion. So all the needles have two different handles. So the first is the amount of sheath that is taken out from the working channel. And the second one, okay, let me see, just one moment. Okay, so now we are going to, okay, you can see here, can you put the pointer? You can see here the tip of the sheath of the needle. This is not the needle, this is the sheath of the needle, okay? So that is going to protect the working channel, to not to damage inside the working channel. And now we are going to introduce the needle. The needle is going to be, as you can see here, in this position. And
Jose,
now,
do you find any difference in terms of easy, or you find it's more complex to use the FMB as compared to the FNA needle?
It's
now
not,
you're switching for a 25 to a 22. What deserves a comment from your side, and from Danny's side? What do you believe on when you're starting to do FNA or FMB? What would be your recommendation for the beginners?
I would recommend them to use at the beginning the histological needle. You avoid to take more passes. Even you have to do less movements or through and fro inside the lesions. At the beginning, for the starters, I would recommend that. And if you have to do a second pass, I would recommend them to use the cytological needle with a rose, just to avoid to do a third or a fourth pass.
Okay, thank you. So,
yes.
Jose, what do you...
I believe this is not a matter of FNA, FMB. The technique is exactly the same. And with the same diameter, it's exactly the same level of difficulty. So the problem here is that now we are puncturing with a 22-gauge needle. That is a thicker needle than a 25. But even in this situation, it's very easy to perforate inside this lesion, because this lesion is not a very difficult one. So in these cases of a huge mass, we have a very high diagnostic yield when we are doing a FNA or an FMB.
Peter was commenting in the panel discussion that he absolutely moves and also took out to FMB. So I think we've also moved, and we've just commented, we've done the 25 cytological one because we just wanted to show what is rows, how we do rows, and how the sample needs to be managed when you want to do a smearing. But what we are going to show you now, once Jose finishes, is how we usually do it every day, because after working together we have decided to move to FMB because the quality of the sample is very good. We have a very nice accuracy because we check every month the results of the sampling that we do, and we decided to move to FMB because if you want to make a comment, you have a rector on the quality. Do you think it's better the quality that we give you with FMB as compared to FNA? Yes, of course. I mean, I think that now Jose is going to show again with Danny on how we are going to put the sample. Now we are going to use a tube, and inside of the tube we are going to use this material, which is a cytological solution. This is Cytolite. If you ask me if you can use formalin, you can. But we have tried and moved to cytological solutions because it gives us two possibilities. We can do histological evaluation, but we can do monolayer because we can obtain, after the centrifugation, some cells. So the advantage of cytological solutions is that you can do both evaluations. You can have sample for cytology and sample for histology. It's only one trick, and the main trick is that you need a specific device for rapid centrifugation. So you need to check with your pathologist is they have the facilities to be able to do this management of the sample. So do you want to show to the camera the sample obtained with the 20? If we just can focus on the image of the camera now. Okay. So probably if we turn upside down, okay. Now I think you can see the large core that we have obtained, completely different. Is a larger, it's really a tissue core, not like when we've done the previous case with the smearing with a very scant sample. However, Hector is going to show us the smearing, so the samples that we obtained for the first puncture with the 25. You see, it's completely different. One is core, and this is some cells. Just want to tell you because Hector have already took a look at the samples. And we have already had the diagnosis, so in this case, thanks to the efforts of the pathologists, we already know that this is a pancreatic adenocarcinoma. However, it's going to be very important for the FMB core sample that we will try to do some stainings and probably some molecular testing, because in this case, with this mass, we will try to find if there is any potential target therapy to do some kind of personalized medicine. So I don't know if any comment from Jose?
No, it was a good case and a very neat case, and I believe that about the complication of the technique are very low, so we are discharging the patient after 1 or 2 hours after the procedure, and in the majority of the cases we lack of complication by doing both FNA, neither FNA or FNB. The rate of complication are the same, so it's a very safe technique.
Danny, any comment from your side?
No, I think it was a good case, a very quite easy function actually, and finally the patient has been diagnosed and we can continue with the therapy.
Okay, so now I think we've done with the case. So now I give the word to the pathologist, because I think we'll have a small presentation. I don't know if Peter or Takao, you have any comment? You deserve any comment from your side about the case?
Yeah, I wanted to thank the team who did again an excellent job to present the method. Jose, I may not fully agree with you regarding the method is precisely the same, because FNA is much easier to get the needle in, and you can actually control. You don't need to stab with an FNA needle. You can slowly go in, and for beginners of the method, I think it's better to do this controlled instead of the stabbing method that is needed for the FNB needle. But wonderful job, thanks.
Okay, so if you agree, Peter, we are going to move to Hector's presentation, because we want to have the pathologist's view, because we are all endosonographers. Takao is performing a lot of procedures. Peter, you're doing a lot of procedures. We are doing a lot of procedures, but we are endosonographers. And I think it's mandatory to know what are the thoughts and what are the vision of the pathologist. So I've just asked Hector to have his overview. So Hector, please come to the camera. We will have the presentation, and he is going to explain briefly a summary on the pathologist's view on the AUS-guided sampling. So thank you, Hector and Ihab, for being part of this event. It's a big pleasure. We know we have close friends. You will see in the slides. So please, Hector, go ahead.
Thank you very much for the invitation. And we are talking about the pathologist's view on tissue sample quality. ¿Esto va a pasar? ¿Es este, no? Sí. Okay. No. And try to break the wall. The most important cytological preparations in endoscopic ultrasound are diff-quick smear, that is the classic cytology, and cell block that is more similar to a histology. Diff-quick smear is a commercial Romanowski stain variant used to fast staining, and is the choice method for rapid on-site evaluation, that is ROSE. We prefer the use of fine needles, like fine needle aspiration 25, to avoid bleeding and tissue cores, because tissue cores are not useful in ROSE, so it's better deposit them in a fixative solution for cell block preparation. ROSE is in general recommended because help adjusting the biopsy target, ensures a sufficient sample, reducing false negatives, allows control of the sample by the pathologist, and ultimately improves the diagnostic adequacy. But not every institution can provide ROSE, and operators with a high non-ROSE adequacy rate had less benefit from ROSE. So we think that in this situation, ROSE can be reserved for especially difficult cases. Sorry. What do we need for ROSE? We need a cytopathologist on site, good communication with the endoscopist, and basic materials like slides, a staining kit, and a microscope. This is a staining kit with a fixative solution, eosin, methylene blue, and water for washing. The result after processing is diff-quick stain glasses to quick check under the microscope. On the left, we can see a picture of a pancreatic ductal adenocarcinoma from a deep quick smear, and on the right, the classic honeycomb pattern of this tumor. The second important cytological preparation in endoscopic ultrasound is cell block that resembling a histology, it's like a histology, consists in the retrieval of small tissue fragments processed to form a paraffin block. We prefer the use of thicker needles, like 5-needle biopsy 22, to obtain tissue cores. The more, the better. It's indispensable for the pathologist because increased cellular yield improves diagnostic accuracy and allows the pathologist to perform ancillary tests like immunohistochemistry or mutational analysis. Remember that immunohistochemistry is necessary for diagnosis of non-adenocarcinoma neoplasms, is the case of neuroendocrine tumor, solid pseudopapillary tumor, or lymphoma, and mutational analysis is demanded in unresecable pancreatic cancer. What do we need for cell block? Only a echoendoscopist and a specimen container with a fixative solution. This is a specimen container with a fixative solution and the sample that after processing, we obtain a paraffin block that provides multiple tissue sections for hematocylin and eosin, immunohistochemistry, and mutational analysis. In the corner, you can see several types of tissue cores that are small fragments or small cylinders that can be processed like a histology. On the left, we have a histological picture of tissue cores, and on the right, pancreatic adenocarcinoma from cell block with hematocylin and eosin stain. This is a picture of a non-adenocarcinoma neoplasm from cell block that, thanks to immunohistochemistry for neuroendocrine markers, we can diagnose as a neuroendocrine tumor. It's important to talk about the Papanicolaou Society of Cytopathology guidelines, that is a classification that proposes a standardized terminology and nomenclature system that provides intra- and interdepartmental guidance for diagnosis and which correlates with biological behavior and management recommendations for pancreatobiliary lesions. There are 6 categories. One is non-diagnostic, is the case of gastrointestinal contamination. 2 is negative for malignancy, like acute or chronic pancreatitis. 3 is atypical. 4 is neoplastic, is the case of gastrointestinal stromal tumor or pancreatic neuroendocrine tumor. 5 is suspicious for malignancy. And 6 is positive or malignant, the case of the common pancreatic ductal adenocarcinoma. And finally, only 3 take-home messages that are: 1, communication between pathologists and endoscopists is indispensable. 2, ROSE is recommended, but operators with a high non-ROSE adequacy rate had less benefit from ROSE. And 3, a good cell block is a safeguard because it allows pathologists to make a complete diagnosis and perform ancillary tests with prognosis and treatment purposes. Thank you very much.
Thank you. Thanks a lot for this excellent presentation also. May I ask you one question, just because I don't know. You are putting your specimens in cytolite. When it's received in your lab, the core that is in it, apart from making an imprint, are you putting that in formalin before you put it in? Yes.
Yes, I'm here with both of them because we work together and I go many times to the pathology department and that's the routine. That's why we switch, in fact, in the room to cytological solution, Peter, because the sample can be managed in both, in 2 ways. One is like then placed to formalin to do a standard core tissue sampling management of whatever we obtain from any lesion. But the other good advantage is sometimes we don't have the diagnosis from the core, yes. But we have the diagnosis from the remnant of the cells. So that's where, for me, if you go for formalin, you cannot analyze the cells. No. It is just for the core. But if you use the cytological solutions, you have two options. So you can increase by 5 to 10%, correct me or not, Hector?
Yes.
By 5 to 10%, we can increase our diagnostic yield when we use these cytological solutions. Of course, when we do liver biopsies, on the other hand, we just go for formalin, on the other hand. But when we want to analyze pancreatic tumors, when we want to analyze suspected lymphoproliferative disease, we have reached the consensus, for instance, between the Hector, Ihab, Jose, Danny, and myself to go for cytological solutions to have to cover a bigger breach of sampling evaluation.
Thanks a lot.
Julio?
Yes.
Hey, congratulations on the establishment of an excellent system collaborated with a pathologist. I have no comment or question because loads is not available in my unit. I just envy you. Thank you.
Yeah.
Well, I can give you anything from my unit, but there is a couple of things that I will not allow to go to Japan, and one is Hector and the other one is Hab. They will stay with me. I was just a final comment in this regard. You saw the picture that Hector plays with Hab and myself. You cannot imagine the good relationship we have between Jose, can also make a comment, and Danny. I mean, we work as a team, and I think this is essential in AUS guided sampling. Sometimes we do not get the best sample. We've been working together, Ihab and myself started in 2005 with the sampling unit in Santiago. So we've learned a lot together, and I've learned a lot on how to obtain a better result after talking a lot of times with them. So sometimes we tend to send a sample with no information, and we need to have more relationship, and even in a single case, you need to tell them what your expectations from the case, because if not, you will decrease your diagnostic accuracy and your diagnostic yield. So it's very important to have a very straight relationship, not only personal but also professional, with your pathologists, and listen to them. Listen to them. Sometimes you are not aware of all of the things they can do if you don't listen to them.
That was a good conclusion, I think. In sake of time, thank you to your wonderful team. This was awesome.
Okay, well, just final word, because I need to disconnect. I will not join the end because we need to wake up the patient. So I would like to thank all the team, Jose, Danny, Alba, Alejandra, Sandra, Hector, Ihab, the boss that is not here. So thank you for all the team, because all of this unit works because we have a very good team working together. So thank you for the opportunity for Endoscopy On Air and Mediglobe, Peter and Takao, for sharing this very nice session together. And running out of time, I give you the word, Peter.
Thanks a lot. It's unfortunately time to close our session. And it has been really a pleasure. I think it has been a great discussion. Martin, did you have
Peter,
a few words?
Thank you. First of all, thanks to the audience and the participants. It's always great to see how many people are listening to you. And of course, thanks to Takao, to you and Julio. It was great and interesting every time, again, learning and learning. And yeah, I'm looking forward to have more of those events. And thanks, Peter, for hosting that. And again, Endoscopy On Air to have these platforms.
Thanks a lot. So we are a little over time. I had a few slides with votings. Is there time to do so, or what? Yes, okay, we'll have it. So let's vote as a final event. What is your choice of needle type and size for an optimal histology sample? Is that a 19-gauge FNA needle performs better than a 25 or 22-gauge FNA needle? All needles perform similar regardless of size. All F&B needles perform similar if size is equal. The crown cut 22 gauge F&B needle performs significantly better than a side beveled 20 gauge needle. A side beveled 20 gauge needle performs better than a crown cut 22 gauge F&B needles. Please could you vote? Let's see. Now, number 4 is heading right now, and there are some who are in favor of 19 gauge FNA needles perform better than a 25 gauge or 22 gauge FNA needle. All needles perform similar regardless of size. We are talking about histology now, and now I think the poll is ended, and if you have to choose a needle type and size for an optimal histology sample, then a 19 gauge FNA needle performs better than a 25 or 22 gauge FNA needle, because the bigger the needle, the more histology you get. All needles perform similar regardless of size. Not true, because an F&B needle takes better histology than other needle types. All F&B needles perform similar if size is equal. That is not true. A side beveled needle doesn't perform as good as a crown cut needle. The crown cut 22 gauge F&B needle performs significantly better than a side beveled 20 gauge needle. And that is true, according to a randomized study. So these are some of the take-home messages. And next slide, let's vote once again. I have to get rid of this. Pathology preparation of specimen is the same regardless of the needle type used, FNA, F&B needle. Preparation is not the same, but sensitivity is much higher for F&B needles. Preparation is the same, and it is good to use F&B for cytology. Preparation is not the same. You cannot perform cytology with F&B. If the pathologist wants to use smear cytology, this is possible in addition to a histology preparation in formalin. So let's vote and see how much of our take-home messages have been understood. People are still placing their bets. And right now, what is heading is preparation is not the same, but sensitivity is much higher for F&B. That's what people think. 39%, 40%. I think, yes, this is finally voted. So preparation is not the same, but sensitivity is much higher for F&B. And that is not true, because, I mean, preparation is not the same. That is true, but there's similar sensitivity according to the studies that we have. So sensitivity-wise, whether you use an FNA or an F&B needle will be the same, but histology is much better with an F&B needle. The next preparation is the same, and it is good to use F&B for cytology. Of course, not true. You need to, you don't use F&B or the histological core as a cytology specimen. That makes no sense. You have to prepare it as histology. Preparation is not the same. You cannot perform cytology with F&B. True preparation is not the same. You can perform cytology, but as an imprint, but the core should be prepared as histology. If the pathologists want to use smear cytology, this is possible in addition to a histology preparation formally. Absolutely true. You can use both, but the core should not be smeared. And I think that is actually our final results and my conclusion remarks, because this was exactly the take-home messages that we wanted to place. Thanks a lot for your attention. Do you have any final comments, Takao, or?
I enjoyed very much today, so I learned a lot. Thank you very much. Thank you. It's support.
Pleasure having you. Thank you.
Thank you, Peter. Thank you, Takao. Great.